So welcome everyone to the Mosaic of Mental Health session number 2. I apologize again for snafus in the Zoom link. Hopefully, well, if you're here, you've made it in, so that's great. I'm sure we'll have some people trickling in. What I want to do now is call your attention to anyone who is interested in getting CME status. And Matt, if there's anything that you would like to say, I'd love for you to come on and share it now.
Thanks everyone for being here. I see a few people still trickling in, but it's our pleasure to host and accredit this course on behalf of the Cure JM Foundation. If not only for CME status, but also to evaluate this course, we would like you to complete this process. There are 2 ways to do it. The first one, you're looking at a screen that has a phone number. This is a text-only phone number. If you are in this session, you have made an account in our system and hopefully added your mobile number to it. And all you have to do is text that 6-digit code in blue to that phone number listed there, and you will be automatically signed in. This is basically our sign-in sheet. I know you've all been to conferences where you walk up to a registration desk and grab a pen, sign the sign-in sheet. That's a thing of the past, and now it's done via text message. There's also a way to do this via your desktop, and that link is in the chat, and I will put that in the chat a couple of more times. The only thing you can do on that site is enter this 6-digit code. So you can't get lost. There's only one thing to do there. Following that, you're going to receive an email in your inbox with a direct link to the evaluation. The evaluation is important to us. We use that data. I'm a data junkie. I know Suzanne is as well. We use that data, your data, to make our programming better. So please do this process for us, not just for CE credit, but to complete the evaluation. Any questions? I'll be here in the chat the entire time. Feel free to reach out. Also, you've received an email from me. Hit reply to that, and you can get directly in contact with me. Any other questions? I'm here, like I said, and I'll turn it back to Suzanne. Thank you all.
Great, thank you. Thanks, Matt. Welcome, and I'm going to ask everyone to put themselves on mute. We'll have some presentations, and we'll have some time in breakout rooms, at which point I would love for you to be on camera in the breakout rooms. But in the meantime, we're going to be silenced until except for the person who's presenting. So first off is going to be Alana Goldstein. She's going to talk a little bit more about Alana Goldstein-Lever, I apologize, a little bit about safety planning for suicide risk. If you were here last time, she did a lot of presentation around suicide risk assessment, and we would like to follow that up. Alana is a pediatric psychologist at Nationwide Children's Hospital, a clinical assistant professor at The Ohio State University. Dr. Lever is the team psychologist for the Department of Rheumatology and Neuroimmunology Clinic within the Department of Neurology. She provides psychological services to children and adolescents with rheumatic diseases and neuroinflammatory disorders. Dr. Lever is also engaged in program development and clinical research focused on pediatric pain management and psychology integration within the pediatric rheumatology care. Please welcome Dr. Alana Lever.
Thank you, Suzanne. Well, I'm very happy to be here to discuss safety planning. As Suzanne mentioned, we previously did review suicide risk assessment, and I do have no financial disclosures to share. So today we're going to summarize that suicide risk assessment. We went over quite a bit and it's been some time. So we'll briefly go through that protocol. We'll review a safety planning intervention so that you will feel comfortable with safety planning with your patients if that is appropriate. And then finally, we'll just apply safety planning briefly to a case example so you can see this in action. All right, so we'll start things off with a recap on I'm just going to move this over in case you're seeing it, with a recap on suicide risk assessment. So we will be using 2 measures for suicide risk assessment, the Ask Suicide Questions and the Columbia Suicide Severity Rating Scale. The ASQ, or the Ask Suicide Screening Questions, is that 20-second measure I discussed last time. It's 5 questions in total. Well, 5 questions, including the last question, if there's a positive on the first 4. Essentially, what you need to think of with this measure is if there's any yes to these suicide questions, you need to move forward with a further measure, the Columbia, that suicide severity rating scale. So if you do see a positive on here, a yes, you're going to be doing some further assessment, and you're going to be using the safety protocol, which is part of this Columbia umbrella. It's this survey that is used for suicide severity rating, and it's really wonderful because it's evidence-based. There's a lot of empirical support behind it. And so that gives you some support in utilizing this to do something that you might be less familiar with. So what we have here is the safety protocol. We have suicidal ideation indicated, ranging from passive suicidal thoughts of wishing to be dead to an intent with a plan to end one's life. So really wide ranging, and you can see that there's colors that correspond to what the risk level would be. So mild risk if in the past month, passive suicidal ideation, ranging from high risk if we've had a suicidal plan with intent or without. We also are going to assess for risk and protective factors that will indicate whether someone is more or less likely to end their life or try to end their life. And then we will also ask a few more questions about suicidal ideation and how frequent and controllable it is for the patient, as well as suicidal behaviors. And these are all neatly packaged in this one questionnaire, this one measure. So you don't have to be reinventing the wheel. This is a resource that is freely available, and we'll provide the link for it. Now, the risk stratification is the last step in the safety protocol, where we delineate between who is high risk, moderate risk, and low risk based on the information gathered. Someone with suicidal ideation with intent or with a plan and intent in the past month, those patients would be high risk, as well as any patient with suicidal behavior in the past 3 months. And those patients would require a psychiatric evaluation. If they were seeing someone like myself, I might be able to safety plan depending on the situation. But for your purposes, I would definitely recommend following the safety protocol and really making sure a mental health professional is going to evaluate these patients. For a moderate risk, that would indicate suicidal ideation with a consideration of a method without plan or intent or behavior in the past month. It could also constitute suicidal behavior more than 3 months ago, or having multiple risk and few protective factors. And that is going to be our cohort where we will most definitely do a safety plan. Addition to that, we have the low risk, which would be wishes to die, more passive suicidal ideation, suicidal thoughts that happened 1 month ago, that are less active and current, and anyone who has modifiable risk factors and strong protective factors would be more so in that low risk profile. And for these patients, we might recommend an outpatient referral for some counseling. With the safety protocol, they don't necessarily indicate doing a safety plan. I would recommend it as part of your care, just because it's going to reduce risk for the patient and also for you in terms of what you're doing in clinic and the service you're providing. So now we're going to progress to safety planning, and we're going to base this on Stanley and Brown's 2012 study, where they delineate this beautiful, brief intervention to mitigate suicide risk. All right, so there are different steps to this safety planning intervention. We first recognize warning signs, employ internal coping strategies, things kids can do on their own, use social supports, both for distraction initially, then for some help in resolving the suicidal crisis. And then finally, we're going to contact mental health or crisis resources or give them that information and restrict access to lethal means. So make sure they can't get access to the things they're saying they might end their life with. All right, so we'll start with warning signs. So we're going to identify those warning signs that precede a suicidal crisis. So you're going to ask the patient, what comes first? Are there certain events that come first? Like, have you consistently been bullied before? Or has it been that you feel really sad or down? Are you having hopeless thoughts? So things like, I can't take it anymore. Even just things like being more withdrawn, more to themselves, or crying more frequently, those can be some signs. But we really want to have the patient elicit and share with us what those signs are for them, because that's going to really vary across parties. We're then going to have them identify some internal coping strategies. What relaxing and distracting things can they do independently during a crisis to help them self-regulate, to help them distract enough to prevent escalation or further escalation? So again, we want to identify the warning signs early and have them use these skills so it doesn't escalate to a suicidal crisis or an attempt or a more extreme behavior or emotions. So for these, this could look like going on a walk, listening to music, even just like looking at a silly video on YouTube. For my patients, I often like to give them a couple relaxation tools, taking some deep breaths, but this doesn't have to be fancy. This can just be the things that help a certain child or patient to help them self-regulate and distract. Then we're going to utilize some social supports for distraction. Now, this is to help the patient to socialize so that they can distract from the suicidal thoughts. This is not someone to help them to solve this crisis in the moment. It's to help them feel connected and distracted. So this might be their peers, this might be their sibling. This doesn't need to have to be an adult, because they're not looking for problem solving to help with these suicidal thoughts yet. They're simply trying to distract with some interpersonal support. Now, we want to clarify that we're going to discriminate between social supports for crisis resolution. So this is when a patient is advised to inform an adult that they are experiencing a suicidal crisis. We want these individuals to be over the age of 21, someone that they feel comfortable sharing with, and someone who would be helpful. So if there's a real conflictual relationship with mom, I would not suggest that they necessarily tell them. Maybe we'll go to dad instead. Maybe there's a different caregiving situation, and it might really be best to inform their aunt or someone else in their family system, or even a caregiver just in their community. So this might look different depending on the kid. For some patients, they can't identify someone that they know, but they are willing to use a crisis line. And I will utilize that as an appropriate support for them if they identify that ability to reach out to that crisis line. But you will see that this is more of a disclosure. So we want to be sensitive about who that patient identifies, and even have them inform that person, hey, if I get to this point where I'm really distressed, I might come to you, and get them to give some sort of agreement to that so that there's that comfort to reach out to them again. We also want them to know crisis resources and mental health professionals involved in their care. So this is when we review counseling resources that they might have or that you're giving them at the appointment. This might be 988 so that they know that crisis line to call if those adults in their life aren't very helpful in that moment. Or this is when we talk to parents and kiddos about when to go to the emergency department. Certainly, if there's suicidal thoughts with a plan, with an intent, we want them to seek out that emergency department resource. We also want to keep the home safe. So means restriction is one of the most helpful ways to decrease suicide risk, because if we don't have access, then the patient cannot take their own life. So this might look like securing medication, firearms, knives, even something that can be used for hanging, if that is something that a patient's considered. Ligature risk, we want to also make sure those are secured in the case the patient has considered that for a method of suicide. This, I would say, is something I would really recommend doing for those patients with a suicidal plan. I always recommend securing firearms at home, because even if it's not part of the plan, we want to assess for firearms at home and secure them, because that is the fastest and easiest, most accessible way for a young person to end their life. So always making sure those are secured, regardless of the situation with their plan or intent. And then patients at moderate risk, they might also benefit from some restriction too, depending on the case. So I wouldn't be afraid to be a little bit more restrictive, have parents supervise more if this is a patient with moderate risk. Now we want to focus on their reasons for living. Why do they want to be here? what's important to them, what's worthwhile, and help them to promote a more future-oriented focus. So we are going to do an example because we got to bring this to life. So let's say we have a patient, a 14-year-old female with a history of arthritis and self-injurious behavior. So this is a patient with a history of cutting who presents with suicidal ideation with a plan, and she has a plan to ingest medication. So after a suicide risk assessment, we would identify a safety plan and work with her on a safety plan potentially. So for this example, what would warning signs be? Bullying at school, in her case, is an activating event or thing that triggers for her suicidal thoughts. Staying to herself, crying more than usual, and feeling sad and overwhelmed. Internal coping strategies, taking deep breaths, watching YouTube or listening to music, and even snapping a hair elastic on her wrist. Sometimes that's used among patients who cut or engage in self-injurious behavior because it gives them a little bit of that sensation that they get with cutting without causing damage or harm to themselves. Then identify social supports for distraction. So friends, family, people they feel comfortable with. Crisis resolution supports. So people who can help them if things get really escalate and they need more support with helping them with these thoughts. Their parent and then their school counselor. So people across settings. And then finally, we want to restrict means. So secure sharps, because this is a patient who has cut themselves. So we want the safety plan to also apply to the cutting, medication, and then again, always the firearms in the home. And then resources, counseling referral, 988, and reasons for living. So in her case, her mom, her Aunt Amy, and her cat, and becoming a graphic artist. I would say this is a pretty typical case that I would see. But I did want to give us just to check in and see if there was any questions about this. We have a couple minutes left, so I just wanted to check in.
Actually, Alana, there are questions in the chat, but
Oh,
I don't think we're going to have time to answer them.
Okay, yes.
Here,
Well,
but
I'm glad I was
a
little fast today.
Yeah,
Good.
I would love for you to look at them and go ahead,
Sure.
Tala.
All right.
Sorry, so we do have 2 minutes, just given looking at the time. If you can tackle one question, Alana. There's so many in the chat, I put a lot. But again, Megan had a question. If they tell you their plans to cut the risk, should you still restrict other means like locking up prescription drugs?
Excuse me, I'm so sorry. I'm having some issues with my Zoom. Can you repeat that one more time, Tala?
Right. So if they tell you their plan is to cut their risks, should you restrict their means like locking up prescription drugs? It's a question from Megan Curran.
So what I would say is if a patient is indicating to you an active plan, like within the past month that they're going to cut their wrist and that they have an active plan with intent to do it, I would send them to the emergency department in that case. In the case that they have had that plan, like that's been something within their lifetime, but not the past month, then I would say restricting the sharps in their home. But I would explore if they've considered other methods. I would have, when you assess with the suicide risk assessment, you are going to broadly assess what else have you considered ending your life with, and assessing other means or methods that they might have considered. And so I would say that most definitely I would secure sharps. I think you are always safe to just secure in the home, especially if they don't have mental health supports. So for me as a clinician, it might be, I might have a little more flexibility if I know the family, I'm seeing them next week, but you might not see them for 3 months. So it might be more helpful for you to actually give a little bit more of a more general recommendation for securing means, especially if you're providing a counseling referral and you don't know the disposition, you don't know how long they will be getting linked with counseling, and they have risk factors. I would certainly say never feel like that is inappropriate to further secure methods or means at home, just in the interest of safety.
Thank you so much for that answer. Very helpful, Alana. So there are lots of other questions in the chat. If you can tackle those while other talks are going on, it'd be great. So I'm just going to go ahead and share my screen, Suzanne, for the next part.
So Tala will be talking to us about mental health screening workflow and logistics. For those of you who are not familiar with Tala, she is Dr. Tala El Tal, currently a clinical lupus research fellow and a recipient of the Jeff Carr Fellowship Award. She's at Hospital for Sick Kids or sick children in Toronto, Canada, and she completed her pediatric rheumatology fellowship there. And she has a strong interest in mental health and quality improvement and patient safety.
Great, thank you so much for the lovely introduction. So really my talk is about tips and tricks, or really this practical steps you may want to consider when implementing routine mental health screening in a rheumatology clinic. I know some of you already have a routine screening done at your site, so I'd be interested to hear some of your approaches. And I would like to point out that this is one approach. There are multiple ways of doing this, but the approach I'll be presenting is really through a quality improvement lens, and hopefully you could take some of those logistics and insights and circle back to your sites. So here we go. So I have no relevant disclosures. So the first step, really in any quality improvement project or improving routine mental health screening, is identifying a target for improvement. And then part of that is you want to assess the baseline performance. So what is actually going on at your sites? Do you have any form of mental health screening? And if you do, how well are they performing? The other question to ask is, what are the resources available to you? So are there on-site mental health personnel? And if not, are there other key stakeholders who are engaged, such as adolescent medicine, psychiatry, social worker? And are there funds that you could secure for such an initiative to really help secure some of those resources? As we know, that is kind of one of the biggest barriers, right? The mental health resources piece. Another question to ask is, who are the stakeholders involved that could influence the process? So really important to involve these key stakeholders, like whether it's adolescent medicine, psychiatry, social work, patients and families upfront during this process. That this sort of transparency will create trust and encourage engagement of these stakeholders in the process, and will make this a lot easier down the road. The other thing to consider is the timeline whenever you are setting a target. And just a quick tip here, if when you are developing an aim or a target for your process, making it specific, measurable, actionable, realistic, and timely are kind of the, as an acronym that I go by to really make sure that this could work out. So as an example, so I'll be using my QI project for improving mental health screening in our lupus clinic at Sick Kids, just as a release, as an example to put these messages through. So our aim was to improve the screening from 17% to 80% of patients using the PHQ-9 G87. And the point of this is that once we've screened these patients, the hope was to improve really the mental health interventions for these patients, so getting them the resources they need from 22% to 80%. So our initial target was September 2022, which frankly, thinking about this now could be a little bit more realistic in extending that time. And the ultimate goal is really to optimize mental health care. The second step here is to create a multidisciplinary team. And so part of that is involving, again, key stakeholders, including patients and families, kind of asking who is on your team. So from staff, nurses, fellows, residents, clinic coordinators, even admin clerks. Thinking also at a higher level, an organizational level. So is there a mental health strategy kind of happening at an organization level that you could ensure that your project is synergizing with some of those key goals of the Institute? Again, this will help maybe leverage some of their resources if it is in line with the institution. And then also, again, thinking about the other key stakeholders and mental health providers, as I listed there. And so the third step is really, before diving in to fix the problem, you want to identify the root causes. And what are really some of the underlying root causes of why perhaps we're not having mental health screening, or why there's poor routine mental health screening rates. And once you've gone through identifying these root causes, and I'll show you some diagnostic tools you could use, you can prioritize which causes to address first. So if I can have all of you just to mute your mics, whoever's not speaking, would be great, because I'm just hearing a bit of feedback. And if you're not sure which causes to tackle first, you could collect some data on some of those root causes identified to really ensure that all that time and energy spent on that root cause is some of the greatest root causes. So some basic diagnostic tools that we used included fishbone diagram, process mapping, as well as Perto charts. So all of these are kind of different QI tools, but I think the key one for us was just sitting together around with the key stakeholders from patients, families, healthcare providers, and mental health personnel, and sitting there and trying to understand why there's poor routine mental health screening. And there's so many, you could see so many different barriers flagged here. And from those, you could generate themes. And from there, you could vote on some of those key root causes. And again, it's really important to really incorporate patient and families' voices in this and try and understand their take on routine mental health screening. And overall, there was an actual positive response from patients' families when we asked them. And something they did highlight, actually, that it didn't take too much time in clinic. So I'm just showing you here the patient's feedback, but there's also parent feedback component to this. The other interesting thing is they flagged that sometimes a follow-up plan wasn't always in place. So again, you don't want patients to fill out these questionnaires and then feel like they've been, used in some ways, that there hasn't been a follow-up or clear action plan in place. So this is a really important issue that was flagged here. So once you've identified those key root causes, you then flip them into what we call drivers. And from those, you can have different change ideas of how you can tackle them. In our case, our 3 key root causes was the lack of integration to clinic workflow. And I remember in the previous workshop, time constraint was really highlighted as one of the bigger barriers. The other issue is the lack of mental health resources, right? So we don't have on-site mental health providers, but we're lucky in that we do have mental health providers who are engaged from adolescent medicine and social worker who were on board with increasing the screening, because again, when you have an uptake of screening, you may end up with more referrals. You want to ensure that there is a clear action plan and that because you have an ethical obligation to follow through that. And so the key 3 drivers were integration to clinic workflow. And part of that, we had patients filling out the questionnaires instead of the physicians to cut down on some of that time. We had an algorithm to streamline the process of reviewing and managing the scores. And then in terms of healthcare provider engagement, we worked a lot on education and part of doing some similar workshops to this. And also in the last piece is patients and family engagement. So by really spending time on psychoeducation, creating mental health handouts and resources, filling out feedback and satisfaction surveys throughout this process to learn from them. And last thing is, so step 4 is really identify key measures. So whenever you're introducing a process like this in clinic, you want to have measures to help track this process over time and see if this change idea did work. And so there's 3 types of measures: an outcome measure, which is your main measure. So that is, in this case, would be the patient's voice, so improving the patient's outcome. The process measure are measures that can help track your change ideas if they're really impacting and changing that baseline of yours. And then the balancing measure are usually unintended consequences that could be negative or positive. So whenever there's an increased uptake of screening, there may be increased number of referrals, and you want to see, is there a backlog for mental health providers to see these patients? Is there an increased time for these patients to be seen? So really important. And once you've identified these measures, you jump into what we call PDSA cycles, or plan, do, study, and act. And so again, to just simplify this, so part of this was really having a clear action plan or algorithm of how to review and manage these scores. And you want to, again, have those key stakeholders on board agreeing on these stuff. And there were several iterations of this algorithm. We started out with 1, and after 10 iterations, we came up with another. And once we've had the final algorithm, we then went ahead and tested it out in a clinic with 2 or 3 patients to start with. Again, baby steps. You don't have to necessarily screen everyone all at once, but you really want to just test out and see the feedback from both patients and also the fellows, the trainees, or the staff, the nurses, kind of see if this is something that will work out. And then this is the algorithm, just to give you a quick glimpse. I won't go through this, but the scores generally kind of, I know this was covered in the last workshop, but they categorize into non, minimal, mild, moderate, and severe. And from each step, there's a clear defined action item. And in fact, it really makes it a lot quicker to review these issues in clinic. And as you can see here, the part of suicide risk assessment on the severe end is really important because the question 9 on PHQ-9 asks about suicide. So really important to tackle there. And so the other thing, and just a quick note here, we came up with a criteria cheat sheet for when to refer to these services for mental health providers. So both social work, adolescent medicine, psychiatry. This helped alleviate some of the anxiety from the mental health personnel, like worrying that there's going to be a crazy amount of number of referrals. But by having this clear criteria, this helped us to determine, when is it appropriate to refer to social work and adolescent medicine. And just step 6 is, do you want to envision, so once you've established all of this, really, is you want to envision how is this going to really work into your clinic workflow. And in our case, we have the questionnaires printed in the morning firsthand, and then so they are paper-based, unfortunately, but I'll come to that in a bit. So the trainee essentially sees the patient and reviews the medical history and exam, and then introduces the concept of mental health care to both patients as well as the caregivers. And really part of this is making this or framing it in such a way that it's part of routine mental health care. And then you ask the parent to wait in the waiting room, and we have the questionnaires handed out to the patients, and they fill it out on their own. It takes about roughly 3 minutes. And we are in the room just in case if they do want to clarify a few questions. And once they filled out the questionnaire, we go back to the main hub room where we do have the algorithm up there, and we review the score and kind of score it and see where the patient falls, in which category. And then we go back to the room and really review the score with the patient, and if appropriate, bring back the caregiver to the room in case there's something that was flagged with the consent of the patient, of course. And we provide the mental health resources to these patients. And then at the end, we plug in those answers into our EMR, Epic in our case. So for now, just a quick glimpse, we do have, as you can see on this, so the x-axis lists the data of the lupus clinics, and the y-axis the percentage of patients that are screened. And you can see the baseline there at 17% shifted up to 57%. So it's still below our target of 80%, but there's a clear shift, an improvement in the percentage of patients being screened. And so far, from the patients who were screened with PHQ-9, 41% had positive screens. For G87, 31% had positive screens. And all to say that the majority of patients are falling in the mild and non-minimal category. And for the patients, when asked about suicide, about 7% had suicidal ideation of 2 of which actually had active suicidal ideation. So it's not something that happens often really in clinic, but when it does, we're prepared in that we do that suicide risk assessment and safety planning. Majority of the patients who were screened did receive psychoeducation, mental health handout, and of those that needed referrals, that were referred appropriately. And the average time frame, I believe we're lucky in that we already have these key stakeholders engaged from adolescent medicine and social work. It's about 2 to 4 weeks on average for these patients to be seen. Key issues that were raised really quickly. I think the main thing is, who is really eligible for screening. Some of the questions that came up, what about patients who do have a known diagnosis of depression, anxiety, but have not received appropriate resources? What about the transition patients? And the question of health literacy also came up, and making sure that screenings are equitable. How often should we be screening the patients? So if you're thinking in a measurement-based care lens, so annual screening versus screening at every visit, tracking the scores over time would be important. Paper-based questionnaires, they're not sustainable. Sorry to say that, but it's really difficult to maintain that. So if you could work with Epic or IT or whomever to automate this process as much as possible, it is really important, in my opinion. And so we are having an app that's going to be incorporated, and I'll get to that later if we have more time. And lastly, I think follow-up in between visits is really important, so that for those patients who do screen moderate, severe, having someone to check in with them, and ensuring that the resources did, so whether it's a referral or they were able to connect with someone in communities to track that as well. So these are a summary of the quick steps. I won't go through them, but just as a quick glimpse, I'd like to acknowledge the Sick Kids Division of Rheumatology, as well as all the QI key stakeholders that were involved in this project. Open to questions. I know we have less than a minute, so please feel free to put your questions in the chat. I'm happy to get to them.
Thank you, Tala. There are questions in the chat and really helpful information. And I know people would like to have some of those response algorithms shared if possible, and maybe even the flow charts. So again, people are trying to answer in the chat if possible. Thank you so much helpful information. We're going to move along to coping and adjustment with Marielle de la Paz. Marielle is a clinical social worker in pediatric rheumatology and lupus patient care liaison with the Comprehensive Lupus Program for Children and Adolescents at UCSF Benioff Children's Hospital. She has a background working with youth directly and in program development for nearly 20 years across a variety of sectors, including youth and workplace development, arts education, and mental health. Marielle is also currently working with a team of patients, parents, and providers to support the development of a child and adolescent wellness center at UCSF, where she lends her special interest in integrating concepts of transitions into adulthood, arts and healing, and mindfulness practices in healthcare. Welcome, Marielle.
So I've been kindly asked to provide some info about coping and adjustment in pediatric rheumatology. This is very broad strokes because coping and adjustment is very multidimensional and very multifaceted. And so I think today I just really wanted to share kind of what I think about when I'm in a clinic and in terms of coping and adjustment, and hopefully it'll inspire and help you think about strategies and be curious about how to address in your respective practices. It's important to think about why it's important. Both living with and caring for a rheumatic condition is stressful and demanding. We know that rheumatic conditions and their treatment present children, adolescents, and their families with significant sources of chronic stress that can contribute to emotional, behavioral, and relational problems, and can compromise adherence to treatment regimens and health outcomes. We also know that chronic illness is a risk factor for major depression and anxiety. Further, many pediatric illnesses are exacerbated by stress encountered in other aspects of children's lives. And then primary care is often the initiator for addressing mental health, but for many of our patients, we see rheumatology becomes the only provider that they see on a regular basis. And so addressing it in our practice becomes essential. I wanted to review some of the common stressors observed, and this is not at all an exhaustive list, and there may be some overlap between the roles. So for patients, we often see some anxiety around the clinic visits, the labs, the procedures, sometimes with hospitalizations. It can create some medical traumas. I often hear patients not wanting to share their feelings, or both physical and emotional, because they're worried they're going to burden other people, including their parents or their people in their social network. Feelings of wanting to feel normal. There's consequences of their health condition, so missing school and missing out on fun activities. There's a social aspect in terms of stressors. So the act of explaining the condition to others, why they've been absent from school, also feeling the burden of other people not understanding what they're necessarily going through. And so they really take that as their responsibility when somebody doesn't understand. And also there's some physical changes and some, worries and anxiety about their appearance and how other people will think if there's physical changes. And then there's pain that creates a lot of stress and anxiety. For parents, we often hear guilt, the uncertainty and the child's future, the ability to keep up with healthcare tasks. Sometimes our patients are seeing multiple specialists, and it's really overwhelming to organize all of that. There's differing value beliefs, and this can be on many levels. This can be differing values within the family. There could be cultural beliefs and differing values between the hospital system and the family system. And then there's also financial burden. Some of the critical times of distress, I find it helpful to review these critical times with with families to create some normalcy in their experience, and also to help them anticipate and plan where possible. So where we see distress are, time between onset of symptoms and prior to diagnosis, at the time of diagnosis, and initial treatment is another stage. And then there's distress when there's a developmental stage or a significant life transition. So for example, from childhood to adolescence or from adolescence to adulthood, that creates some turbulence. And then there's times where, again, like I mentioned before, related to managing ongoing healthcare needs of the child. And then of course, during flares of the condition. So in my, just anecdotally, in my experience, most families need at least 3 to 6 months after initial diagnosis to really settle in and to acknowledge how their diagnosis has really impacted them. And then they can start to get more organized around, proactive coping. And I find that the worst times are right before diagnosis and the initial period between diagnosis and settling on a treatment, and then the response to treatment. Oftentimes families, I put this in, and many of you are really familiar with, stages of grief. Typically it's listed as the 5 stages of grief. Amanda Pratt expanded it to say the 7 stages of grief in order to relate to like chronic illnesses, including rheumatic conditions. And so oftentimes families respond to getting a diagnosis in clinic with grief. And I think it's really important to name and acknowledge it with them. It can help families understand that it's a common and natural response. And these will include feelings of denial, anger, frustration, despair, hopelessness, anxiety, and loneliness. It is also important to say that this is not linear, so it may not go in order, and you may find someone that's kind of hopping around through the different stages or returning to, a particular stage. One of the most popular models describing stress pathways has been proposed by Lazarus and Folkman. Their transactional model emphasizes the person-environment transaction and suggests that stress response is highly influenced by individual appraisal processes. So once confronted with stressors, such as a medical diagnosis and treatment, a person will evaluate the relevance of the stressor as this primary appraisal, and then also their own resources to overcome that stress. So primary and secondary appraisals are believed to have an impact on coping strategies chosen by the individual, and then the coping affects the immediate response as well as long-term health, psychological well-being, and social functioning. And in applying this model, my focus becomes helping patients and families really understand this appraisal process. So their relationship with illness and health, and then what are the coping options that are available to them to improve or stabilize well-being. And I will also say that this model is really helpful in terms of an assessment of families, because over several visits, I'm really taking a look at and trying to understand like the environmental variables and the personal variables that kind of impact their adjustment process. There's not a box here, but I feel like there should be also a box here about kind of the severity of the illness and how that plays into adjustment. So ultimately, when I'm working with young people and their families, the goals are to reduce distress, kind of instill good illness management, minimize the illness interference on life roles, activities, and relationships, and kind of foster the ability to maintain positive affect, or more importantly, resiliency. And then anytime that I'm talking about goals and plans with patients and families, it's always ultimately what are the current goals of the patient and the parent, and to really be explicit about that. So how does this translate into more practical suggestions for coping? There are a variety of coping types, and here are some of kind of the main categories or buckets that I usually teach about. A lot of my time is spent educating families about the varieties, both the variety of coping that they can adopt, and then also as problem-focused strategies. So things like learning about the health condition, learning about rights and resources. You know, I use disease-specific foundations like Cure JAM, Arthritis Foundation, and Lupus Foundation of America. It's like as primary places for them to go. You know, I'd really talk about school functioning and provide both information about like how to talk about the condition, and then also how to ask for accommodations and what their rights are as a person with a condition. And then also there's a lot of coaching in clinics, so things like setting specific, realistic, achievable goals that include planning for dealing with roadblocks, recognizing negative self-talk, and identifying unrealistic negative thoughts and replacing them with positive, more manageable ones, or even just trying to stop negative thinking in their tracks. I often help patients reframe their current experiences into a meaningful one, and identifying purpose in the face of like adversity, and then also identifying and recognizing their successes and their abilities, and not and kind of shifting from focusing on what's missing and the loss. There's also emotion-focused coping strategies when it's helpful and you need to take care of your feelings, when you either don't want to change your situation or when circumstances are out of your control, which is often the case. These two, emotion-focused and meaning-making, kind of go hand in hand with one another. But this is really to assist a person in understanding the relationship with their illness or their condition. So things like talk therapy, including CBT, art therapy, and then also really discussing kind of who needs the therapy. Is it, the family? Is it better for the whole family? Is it better for just the parent, or is it helpful for the child? Things like journaling and expressive arts. And this one's a really big one is really kind of, especially for people that have the chronic diagnoses and are returning to our practices, is really kind of finding the celebrations in their progress, and then ritualizing, the medical experience. Then there's, of course, always social support. So things like support groups, sometimes religion and church serves that purpose for folks, and then clubs and sports and things like that. Diverse set of stressors may require very different types of coping. So, it really depends on kind of what's presenting as the stressor, and then that would kind of inform the coping strategy. So, for example, coping with missing school and falling behind in schoolwork may best be addressed through active and planful problem solving, whereas acceptance and cognitive reframing or reappraisal may be better suited to address changes in things like physical appearance or experience of pain. I also wanted to I thought it would be helpful to just briefly go over kind of how we support mental health at UCSF, pediatric rheumatology. So we do have a few disease-specific programs, one in lupus, and more recently in dermatomyositis. We do have 3 social workers on staff. There's one in San Francisco campus, one in our Oakland campus, and then I serve as the lupus patient care liaison. We do routine psychosocial assessments, both in inpatient and outpatient. Typically on outpatient, it's on an annual basis, at least we try to do that. And then in the inpatient, it's mandatory for all patients to get a social work consult and assessment, whether it's a specific specialty social worker or a hospital social worker. We do have some peer support programs, including a buddies program where we match patient to patient or parent to parent based on their experience, where they live, whatever they feel like will be most helpful, because we find that knowing some other person that might be experiencing something similar is very beneficial. And then we also make sure that social worker provides educational talks to the pediatric rheumatology team to address important psychosocial topics. And then also we have an orientation for any incoming providers or fellows.
Marielle, we are at time. So
yeah, sorry. I'm almost done. This is the last slide.
Great.
So, and then lastly, this is just what my role is. I thought it would be really helpful because I feel really privileged to hold this role because I don't think there's a lupus liaison at all facilities. And so I was hired to primarily serve the patients that have a lupus diagnosis. And then this is kind of what my role is. So to provide education, care coordination, healthcare navigation, to facilitate the peer-based support programs and transition to adult care, of course, provide community referrals and resources, and then most definitely support patients and families, especially in between visits, because we don't have enough time when we're in the clinic. And I feel like that's where most of the hard work has to be done, is in between the visits. And then also supporting communication between all the players involved. So yeah, there's more, but I will make sure that the slides get out to you. Feel free to reach out to me if there are any additional questions or thoughts.
Thank you, Marielle. There are some questions in the chat, so when you have your chance to answer them, that would be terrific. We're going to move on so that we do have some time in our breakout, a little more time in the breakout sessions. We're going to talk a little bit now about cognitive behavioral therapy, also known as CBT. And to present this information is Natasha Cunningham, who is a PhD, tenure track assistant professor in the Department of Family Medicine at MSU, Michigan State University. She's a licensed clinical psychologist. Her research focuses on developing tailored and accessible psychological treatments for youth with chronic health conditions involving pain and co-occurring psychological symptoms. She's currently leading a multi-site study to test the telehealth application of a tailored cognitive behavioral intervention for adolescents and young adults with childhood onset lupus, geared to improve fatigue, mood, and pain symptoms. Dr. Cunningham's research also focuses on training school providers in using CBT strategies for managing student pain and testing neural mechanisms of response to CBT for pain and anxiety in children with functional abdominal pain conditions. Welcome, Natasha.
Thank you for that lovely introduction. I just want to confirm, am I okay to go until about 4:10 or so? Will that work?
Yeah, you have 15 minutes.
Perfect. Okay. My presentation will primarily focus on CBT, or cognitive behavioral therapy, for pediatric pain management, which is something that's often appropriately indicated for youth with rheumatologic conditions. Of course, CBT is well established for treatment of pediatric mental health concerns as well, such as anxiety and depression. And I'll talk a little bit about different strategies for utilizing a combined approach when many youth may be kind of concurrently dealing with different issues. So when we say cognitive behavioral therapy, I think it's great for you as the rheumatologist or a medical care provider to have a basic understanding of what it means for a child to engage in such care, because you play a very powerful role in getting that child engaged and potentially excited about pursuing that care. There's a lot of stigma that can be associated with being identified as having a mental health concern or getting treatment such as cognitive behavioral therapy. And I think your job as the physician, you have many jobs, you're taking care of the kids' medical needs, but as far as getting them engaged in psychological care, I think your job is to really sell it as part of an integrative approach, a whole person approach to care for their rheumatologic condition. I think the majority of kids who are faced with a chronic illness can benefit from a program such as a cognitive behavioral program. So cognitive behavioral therapy for pain management includes three main components. There's a psychoeducational component, and that includes some what we call the gate control theory of pain, which admittedly is an antiquated theory, but it's very helpful for describing different biopsychosocial factors that can affect the pain experience that children receive. We also provide some parent educational guidelines for pain, which I'll show you briefly. There's also a number of behavioral strategies we use to help children to cope with and manage their pain symptoms. These include strategies you may already be familiar with, such as guided imagery, progressive muscle relaxation, deep breathing, or mindful breathing, and those can be paired with biofeedback. We also utilize activity pacing. We find children with chronic illnesses can overdo activities or underdo activities. Both of those can lead to flares and symptoms. So we really try to teach kids to utilize balance. And then something we use kind of very common in the treatment of depression, but also very appropriate for pain management, is behavioral activation, or getting kids re-engaged in enjoyable activities to help promote their functioning. Then we also had the cognitive strategies. These include identifying negative automatic thoughts. These can be about pain, or they can be about other issues that the child is dealing with, and helping the child to generate positive or more neutral or appropriate self-statements. Problem solving is another example of cognitive strategies. Now, you'll notice there's a whole menu of different tools. And really, as a provider, I think it's important to give kids the full access to a number of tools that we know can be effective, and have them practice, because sometimes, like riding a bike, it doesn't go well the first time. You really need to build up some competence. And so we really try to pitch getting kids access to these tools and teaching them to use it to get comfortable, but you will find certain children will gravitate to certain skills. And that isn't a, necessarily a negative indication of other skills. So that's just something to be aware of. So what's really interesting, sometimes I feel like we may have gotten a bit too subspecialized, but oftentimes if someone is coming to see a provider for pain management, it's a very prescribed and specific treatment. So at Cincinnati Children's, for example, where I provided clinical care for a number of years before coming here to MSU, everyone gets training in the same protocol, and in general, kids get 5 to 7 sessions of outpatient hourly care on a weekly basis, and it's very focused on pain management. If they have comorbid mental health concerns, which about 50% of them do, they're then referred to another provider after they finish this course of therapy. To me, that feels a bit piecemeally. I really enjoy, and a lot of my research is focused on integrating these approaches so somebody can get some care for managing their pain symptoms, but then can also get some additional care and support for managing comorbid mental health concerns. And there's pros and cons to different approaches, but just realize your institution, the behavioral care providers at your institution may follow a structured and may follow a very subspecialized approach. In any case, the child is the primary participant. A parent is engaged to the extent that's necessary, and we can flex that depending on the needs of the family. Obviously, there's a bit more parent involvement when we've got younger kids and less parent involvement for adolescents, but some parent involvement is still really important. My goodness, adolescence is a challenging period of life, very transitional kind of period. Someone's trying to spread their wings and wants to be autonomous, but maybe isn't always, utilizing the best judgment because their frontal lobes aren't developed fully. So it's a really complex and challenging time. So we really do try to provide some support to their caregivers educationally and some guidance that can help them with managing their symptoms. Really, and I think this is the important thing to tell your patients, this is not an approach that is, delving into your past, some of the stigma, maybe addressing, if they have concerns or hesitance, or they're just simply not interested in this kind of program, maybe assess what it is that seems like not a good fit, and let them know, really, this is something that is focused, it's appropriate for any child with a rheumatologic disease, and it's focused on teaching specific strategies. It's very skill-based, and again, can be appropriate for anyone managing a chronic condition, and it's meant to be brief. This is not something that someone has signed up for years. Again, 5 to 7 sessions. There's now a lot of virtual options too. Someone doesn't even necessarily have to come back to your clinic to get access to this care. So these are things that I think can be really helpful and increase buy-in, especially from families who are hesitant to get engaged. So the goal really with pain-focused CBT is to try to get a child functioning optimally, going to school, engaging in social activities, really improving their coping surrounding their chronic illness. The secondary goal is, pain improvement, but sometimes what we see is coping improves first, functioning improves, and then pain can improve. But some children, it's just not necessarily realistic to expect that this is some magic bullet that's going to remove their pain. And we really like to, as providers, provide very realistic expectations. Chronic pain can really vary in terms of the duration. And really, we're focused on helping to support the person, giving modifications so that they can live their best lives, so they can have a high quality of life, engage in things they both want to do and need to do. We also want to teach a child to accept their chronic pain condition, and that doesn't mean giving up, but it's a way to reframe and not dwell on the negative and move forward and think about how they're going to be in the world, in spite of having a chronic illness or a chronic painful condition, how they can move forward to cope optimally. We really support attending school, and things have changed in the last few years for obvious reasons. There's a lot of virtual school options, and you may have parents come to you and children who say, you know what, my child really functions better outside of the school environment. They're less anxious. They don't have to worry about, medications or any stigma regarding their physical illness or their psychological illness. And I will tell you, from the perspective of a psychological provider for chronic pain, we really want to get kids physically back in school to the extent that is medically possible. Of course, there are going to be children who medically are not able to participate. That is not what I'm talking about, but really getting a child out of that environment, yes, it can be less distressing, but it's putting a Band-Aid on a problem. It's not solving it. And we really want to get the child in school and engaged and learning strategies that are going to help them not just with school, but then kind of carry them forward in their lives. So that's really a push we make, is to get people who are not attending school back into school. Sometimes too, we notice people get really excited and they start to notice some improvements in pain-focused CBT. Sometimes what happens is they get so excited, they start overdoing things, and then they're prone to experiencing a flare again. So that's something we really like to anticipate and predict for people, because if you think of children and just any of us, different stressors can really make us vulnerable. And some of those things we can anticipate, like the beginning of the school year. After about a month in, people start to fall apart. Summer break, people tend to be doing better in terms of psychosocial stress. So we can help to problem solve and predict potential future situations that might cause difficulties. And we also try to help people not get too overcommitted because they're suddenly feeling better, to where they're getting too active and potentially putting themselves at risk for increased distress and pain flares. So the role of the psychological provider is many. It's really supposed to be a tough love motivator, but who's compassionate and understanding of the child's pain symptoms, can help communicate between different individuals, such as school providers, medical providers, and promote a mind-body connection, and really uses CBT to address pain and teach coping skills. And who can provide this care? Well, right now it's traditionally pain-focused cognitive behavioral therapy, but there's just not enough of us out there. And it can be very frustrating if that is the only answer and you're not located in a place that has access to people with this level of specialized training. So I'm a big believer in trying to teach some of these strategies to other professionals who reach the lives of these children. So I do some work in schools. I think there are people on your medical team who could potentially be trained in these strategies. It could be a very engaged social worker, mental health specialist would be a natural fit. But I think even a medical assistant or a nurse who has the bandwidth and time and wants to be a champion can be trained in these skills. And part of who I'm training right now includes school nurses, because I really believe with appropriate training, we can get people access to care, especially if they have moderate symptoms. I think where we as pain psychologists can come in is potentially helping for the kids with more moderate to severe symptomatology and those additional mental health comorbidities. So I'm kind of getting low on time here, but again, I just want to recognize that pain is only one aspect of what a child with a chronic illness deals with, and mental health issues are a big concern for a number of kids too. So I really believe in taking a multifaceted approach. Anxiety is very common. Depression, trauma can also be common. And I think that there are places for stratified or stepped approaches to care, depending on the level of severity of symptoms a kid has experienced. And there's good evidence that procedures such as CBT can be used to address multiple issues that children with rheumatologic conditions are dealing with or faced with. There's good evidence it can be effective in pain management. There's about a 60% response rate. We see disability often may improve before pain, and gains can even be sustained. And I think this is what's really powerful too for you to communicate to your patients. A medication can help, and sometimes it's very appropriate for a child to receive like an antidepressant to get them kind of functioning better so that they're able to really benefit from a program such as this. But what's great about a program such as this is that hopefully they can learn skills that can last them a lifetime. We really believe if we can get kids access to effective coping strategies, we might be able to prevent some of the long-term risks or outcomes they may be faced with if they don't get appropriate care. CBT is effective, I think, is a good take home. We don't have a lot of additional time, so I'll probably pause here, but I can provide, if people are interested, I have some basic information on some of the strategies we often utilize for children who are dealing with chronic painful conditions, including gait control theory, parent guidelines, which I think is really important because treating a child with a chronic illness, it really involves a paradigm shift. We really manage chronic illness very opposite to how we manage acute pain, where we're kind of attending and paying like a lot of attention and doting. We really encourage a child to take more autonomy. And you'll see a lot of well-meaning parents might be a little over-involved. Again, like I think I would have naturally been that way as a parent myself without having training about kind of what would be best for a child with a chronic illness. So I'm going to just kind of pause there because I think that we are running low on time, but I'm happy to share these materials, always happy to talk with people, and feel free to follow up with me, outside of this opportunity today with any additional questions you might have. And thank you very much for your time.
That's fantastic, Natasha. So again, questions are going to be in the chat. Natasha's really great at sharing information. And again, we're going to move on to learning more about art therapy and play therapy. So Michelle Itzak will be our next presenter. I hope I said your name right, Michelle. She's an assistant professor and the practicum and internship coordinator for the Department of Counseling at the University of Indianapolis. Michelle was the first president of the Indiana Art Therapy Association in 2010 and continues to serve in additional board positions. Michelle was recently elected to serve on the Accreditation Council for Art Therapy Education. Michelle was the founding art therapist of the art therapy program at Riley Hospital for Children in 2010. She maintains her connection to Riley through contractual work with Riley Bereavement Services, where she provides no-cost art therapy services to those who have lost a child. Additionally, she maintains a small caseload of clients through private practice. She recently edited the book Pediatric Medical Art Therapy and was a contributing author to Foundations of Art Therapy Theory and Applications. Please welcome Michelle Itzak.
Okay, thank you so much, Suzanne. I really appreciate your introduction, and thank you for having me here this afternoon. And actually, great kind of connection. One of my very first patients at Riley was one who has juvenile dermatomyositis. I'll talk a little bit about her here in my presentation, but we'll go ahead and get started. One of the things I wanted to start off with was helping people understand the differences between art and play therapy. Oftentimes people can confuse them. Oftentimes people kind of make assumptions about what they are based on the fun terms of art and play. So I wanted to just kind of clarify that. So art therapy is its very own degree. Oftentimes programs are a dual degree. So people who obtain the art therapy degree are also obtaining some sort of mental health counseling license to go with it. So it might be a mental health counselor, it might be a licensed clinical social worker, or an LMFT, American Family Therapist. In several states in the United States, we do actually have art therapy specific licenses. So we have credentials nationally. Our national organization has credentials, but then we have states, for instance, like New York, they have, it's called an LCAT, a licensed creative arts therapist. So a person there can practice with their art therapy degree, and they don't necessarily need the mental health counseling component to go with it. To become an art therapist, the training has to be completed in a graduate program, and art therapists are trained in all the traditional theories like cognitive behavioral therapy, humanistic, Gestalt, Jungian. They're trained in all those therapies that any of your other traditional therapists are trained in. In addition to that, the theory that makes art therapists different and informs their practice is the expressive therapies continuum, and I'll talk a little bit more about that as we get into the process here. Regarding play therapists, I am not a play therapist, but I have worked with them, and I have colleagues who are play therapists. So the difference is play therapists are people who have their mental health professional license first. So it may be somebody who goes through a social work program or an MFT program, and then they decide they want to go get more training for play therapy. Play therapy only has credentials. They don't actually have licenses that are governed by states. In order to become a play therapist, there are a variety of different ways, but that's primarily through training via some coursework and or workshops. So there's some specific training that they can do, but it's not required for them to have that in a graduate program. It's typically something that they go back and get after they complete a program. But again, they're also trained in similar theories as other mental health professionals, CBT, Adlerian, Gestalt, all that kind of good stuff. So I'm going to talk a little bit about each of the different therapies and how they work. So I thought I'd start off with the definitions for each one. So the Association for Play Therapy is www.a4pt.org, and their definition is the systematic use of a theoretical model to establish an interpersonal process wherein trained play therapists use the therapeutic powers of play to help clients prevent or resolve psychosocial difficulties and achieve optimal growth and development. So play therapy is typically used with kiddos who are between the ages of 3 and 12. All ages can benefit if you can convince older people to engage in that, right? Sometimes it's harder for people when they get older to be able to remember how to play or to be willing to engage in play. Play therapy is regarded as evidence-based practice when it's used by trained professionals. It's also used to enhance the counseling process, especially for children. It allows kids to play or act out situations and allows them to learn and problem solve. So for instance, there's a lot of research that shows that when schools take play out of the school day, we see deficits in learning, right? The more children play, the more they learn. That is how children learn, is through their play, right? They don't have the verbal capacity that adults do to exchange and share information, and they don't process and understand the same way that we do verbally. They need to play and engage. They're more of a kinesthetic and sensory level, and that's how they process information. And so when they engage in play or art making, that's how they are really truly learning. Something else that sets play therapy apart is that the therapist directs the play toward an identified goal. So again, sometimes people misunderstand play therapy and it's just a kid playing in a room, but the therapist is going to have a specific therapeutic goal, and they are going to direct the play to achieve whatever that goal may be. I like this quote, so I threw it on here. Play therapy is a way of being with the child that honors their unique developmental level and looks for ways of helping in the language of the child, which is, again, it's play. That's really, truly how kids learn. So the American Art Therapy Association is our national organization for art therapists, and their definition of art therapy is a mental health and human services profession that enriches the lives of individuals, families, and communities through active art making, the creative process, applied psychological theory, and human experience within a psychotherapeutic relationship. So there are some overlaps, right? There are play therapists who use art there, or who use art in their therapy, but they're not doing art therapy. They're using the arts to help maybe advance the play or engage the client in a different way. Art therapists use art very specifically to achieve those goals. So how does it work? Art therapy is for all ages. Anybody who's willing to engage in art making can benefit from art therapy. I've worked with clients when I was in the hospital. My youngest client was 22 months old. So I've worked with from 22 months all the way up to people, in 102. So any age can benefit from art therapy. We continue to have more and more evidence for art therapy. It's especially helpful for people who have mood disorders, things like anxiety, depression. It's extremely helpful for trauma and PTSD. There's a growing body of neuroscience. There have been a lot of art therapists who've been researching the brain and doing brain scans on people who have received art therapy. It's used very widely with veterans. There are a lot of art therapists employed in Washington, D.C. who are working with our veterans coming back because we have so much evidence to show how helpful it is with these mood disorders and with trauma. So art therapy engages the mind, body, and spirit in ways that are distinct from verbal articulation alone. Kinesthetic, sensory, perceptual, and symbolic opportunities invite alternative modes of receptive and expressive communication, which can circumvent the limitations of language. Visual and symbolic expression gives voice to experience and empowers individual, communal, and societal transformation. I could talk for days about art therapy and play therapy. I teach in these programs. So if you want to know more information, feel free to reach out to me and I'd be more than happy to talk to you. I'm kind of giving you the very basics and overview here in our time. So a lot of questions that I get are, when should we refer to an art therapist or play therapist and why? So I'm of the mindset that if we can prevent things, that's our best route, right? So in my opinion, upon diagnosis, if you have somebody who's coming in, a new family, a new patient, and they're just getting a new diagnosis, that would be a great time to start connecting them to mental health services. If it's a young child, since we're talking about pediatrics here, I think to me, it's a no-brainer to refer them to an art therapist or a play therapist. Those people are trained to meet those children at their developmental level, and that's where you're going to be most successful, is when you can meet them at that developmental level. Additionally, that first sign of anxiety, depression, or suicidal ideation, maybe you introduce it or offer it when the family first starts and they're kind of dismissive of it. But then maybe after a few appointments, you kind of start to notice that you see some anxiety or the parents are concerned about this. Art therapists and play therapists, again, they are both licensed mental health professionals. They are trained in how to handle suicidal ideation. So you don't have to immediately go to a psychiatrist or somebody who can prescribe medication. There are lots of different interventions and techniques that art therapists and play therapists can use. to kind of help monitor suicidal ideation and help alleviate anxiety and depression. If you are somebody who has a more holistic approach to patients, which is something that I highly advocate for, yes, they need the medical piece, but I also think that psychosocial support is vital for kiddos who have chronic illness, who are dealing with these kinds of diagnoses. They need the medical component, but they also need that more holistic approach. So if you are somebody who's an advocate for that psychosocial support, that's a great time and a good reason to refer to a play or an art therapist. Another thing that I think is really important for kiddos who are going through medical diagnoses is establishing routine and consistency. As you all know, like the hospital and medical appointments, they can just kind of, there's no routine, right? And kids need routine. That's why they go to school. They have a routine. At home, it's beneficial for them to have a routine. And so getting them established in a relationship with an art or play therapist who can establish some sort of routine or consistency for them is extremely beneficial. I mentioned that I had one of my first patients was one who had JDM, and her routine was every time she would come to outpatient for her infusions, her mom would let me know, and I met her every single time there, and that became an expectation, and that was something that alleviated a lot of stress for her. Art therapists and play therapists can be supportive people who are not connected to the pain that they may be facing, and they can also offer choice and control, right? Again, in the medical setting, children often don't have choice. They don't have control. They don't get to say in what's happening to them. And so by providing them an art therapist or a play therapist, kiddos get that choice and control in those services that they're receiving. And just to reiterate, play and art are both very natural forms of expression for children. So it makes sense, right? If this is what kids naturally do, why would we not want to engage them in some sort of therapy that's just a natural way for them to express themselves? And they don't require verbalizations. A lot of times in play therapy and art therapy, we do talk, but it's definitely not required. And so when we have little kiddos, like I said, the youngest one I worked with was 22 months old. He couldn't verbalize what was happening, but there was a lot of process and a lot of progress and positive change that we saw in him. And then additionally, art therapists and play therapists, they're trained in working with families. So these types of services can include family. Again, my first patient that I had, she was a twin. Her twin didn't have the same diagnosis, but they always brought her to the hospital. And so a lot of the work that I did with them, it involved both of them because they were both being affected, right? Not only the patient, but her sibling. And it was super important to that family that her sister received services as well. And so it was just a different way that we could address those needs. All right, so I think my two biggest whys are the relationship that is developed. That's huge. That's like the most important tool that a therapist can have, is that relationship. And then the developmental appropriateness, which I've already kind of touched on. So the picture here on it's my left. I'm hoping it's showing on your left as well. The little girl with the headband. This is Catherine. She was my patient. I have permission to use her image and her name. I worked with her for about 3 years while she was there. She was diagnosed when she was 5, and she came every so often for her infusions. And I built a really strong relationship with her. And in fact, my relationship started out with her because she refused to talk to any of the other medical staff. Anytime anyone came into her room with a white coat on, she would hide under the covers and she wouldn't talk, she wouldn't do anything. And the doctors weren't able to treat her and figure out what was happening. So the child life specialist consulted me and I started working with her. And the first time I went into her room with art materials and started doing stuff with her, she started talking to me. And so she and I built a really strong relationship and we worked throughout her time and her diagnosis. But that relationship that she had with me, to have somebody that she could be with at the hospital that she could trust and know that when I came in, nothing painful was going to happen to her. That piece was huge in getting her to cooperate with her treatment and getting her to start interacting with the staff and just helping her adapt overall and have that really healthy emotional and mental adaptation to the diagnosis of this life-changing disease that she had. Good news, she's now a teenager. She was a Riley champion, so she went around the state and got to talk about all the positive things that happened to her at the hospital. And she always said that the most helpful thing for her was art therapy. All right, so another question, I want to make sure I'm being mindful of time. Art or play, which one, right? Which one do we do? This is something that I tell my graduate students all the time. They always get frustrated, and it's the truth though, it depends. I would probably talk to the patient and the parents and kind of find out, does the child have a natural propensity for one or the other? Some kiddos are just really comfortable with art materials and they might dive right in and do it. Others may be a little bit hesitant to do that. Some of them may be a little bit more geared towards play or drama. or acting, that sort of a thing. So it's really going to be, it's going to depend on each client. I don't know that there's necessarily one thing that I would say, yes, for sure this or for sure that. And it might be something you might give the family both options and they could evaluate, or you could send them to one and that person could do an assessment and evaluate and see if they think that it's going to be beneficial. So if you have any questions, I'm happy to answer those. I put my contact information here. Like I said, I went through that super fast. I talked about art therapy in about 2 minutes and I teach it for semesters on end. So I'd be happy to talk to you any more about that. If you are interested, like Suzanne mentioned, I had a book come out in 2021. It's specifically geared towards pediatric medical art therapy. That's the title of it. And I talk about Catherine in that book. And there's another great chapter from an author who's in Ireland who's done groups for kids with chronic illness that I think can be very applicable to this population as well. So I'm always happy to talk about art therapy.
Thanks, Michelle. There are definitely questions in the chat, particularly around how to find outpatient art therapists within the hospital situation, so that most of them tend to be inpatient, people are saying, and then also outside of the hospital or clinic itself. So I will let you pay attention to the chat. And in the meantime, thank you very, very much. Maybe you can stop sharing.
Yeah.
I'm going to put people into breakout rooms.
Before that, I just wanted to flash the slide. For whatever reason, the chat was disabled. Sorry, I'm not sure if it's the same for everyone else. I wasn't able to put the questions in the chat.
I'm seeing it. Is anyone not seeing it?
Me then. Okay.
I think we're all, yeah.
So what I'll do then is just share my screen.
The chat is disabled for me too, just as
okay.
release apparently.
I wonder if that's your hospital. Is anyone else having troubles with the chat?
Yeah, suddenly disabled.
Yeah, it's disabled.
We can see it, but we just can't write in it.
Oh, bizarre.
I wonder if it's on Matt's end somehow. Or Christine, Suzanne, you have the control of it.
I'm gonna take a look at it too, by the way.
Matt or Jeff, can you look at it and see? Thank you.
I'll see what I can do here.
Okay.
Great. So I can just go ahead and just give a heads up for people. So we'll have a breakout session for about 15 minutes. The 2 questions we'd like us to just tackle is one, what mental health personnel do you have available at your sites? So thinking about, again, mental health, different mental health interventions and human kind of resources as well. Second question is, what funding resources do you have, if any, and do you have for mental health support specifically? And do you do any sort of billing and kind of the logistics around that? And then once we're back from the chat room, the breakout room, will put our answers into Menti, and I'll share the link in a bit. For now, so Suzanne's going to put us in the breakout rooms. And please assign one for being the note taker so they can put their answers into Menti once we join back. Thank you.
Okay, the chat is now back, I believe. Yeah, great. Okay, I'm going to put everyone into their breakout rooms. We have 7 of them. I'm going to open all the rooms. There might be some need to shift people around. Please let me know if you have more than one facilitator in the room. You will have to choose join, and you will have 15 minutes in those rooms. Tala has put a Menti link in the chat. Again, you can, and I will let her take over now for our full group discussion.
Yeah, thanks everyone. So what I'll just ask you to do is using your phones or your laptops, just put in the link or scan the QR code. So I'd like to hear kind of a little bit on some of the themes that you discussed in your breakout rooms. So if the note takers could go to the first question. So I'm going to go to the first question here. 1 second. Okay, so for the first question, what mental health personnel do you have available at your sites? So you could just put into your answers there, and I'm going to be slowly reading out some of those main themes. So social workers dedicated to vision or to clinic site. Again, social workers, psychologists, pediatric rheumatologists, because we can also learn how to address mental health. Love that. So child life, I'm seeing very similar themes here. Adolescent medicine, behavioral health team. social workers, psych by referral, team psychologist. That's definitely a luxury. Wish we had one on site as well. Psychology and psychiatry department, we refer to the patient, but wait time is long. Something I definitely been hearing at also other sites. So dedicated social worker, outside state resources. That's just flowing in here. Child life educators, medical dogs. I love that. So animal therapy, also big belief on that. Psycho educators, hospital-based play therapy, art therapy, and psychoeducators. So we're seeing a lot of overlap here in some of the similar resources. It's nice to see that there are resources available in some sites, whether it's on-site or resources that you can touch base on. Okay, so I'm going to move on to the next question here, just in the interest of time. So what funding resources, if any, do you have for mental health supports? And then do you do any sort of billing that we could learn from as well? So not sure about funding, no billing at the sites, mostly donations. So very similar back to our discussion, our group at least, a lot of it in Canada is based on certain donations that are made for mental health strategy. No funds and no billing, again, very similarly. All three sites in our room said they had no dedicated funding. So again, very similar theme in that unfortunately there isn't dedicated funding for mental health personnel and supports and resources. So see here, research only for evaluation for lupus patients. So grants also is another avenue. Research funding, government funding, clinical revenue, but mostly no dedicated funding. So it sounds like we got to be creative here in that, whether it's applying for grants, looking at certain donations that could be dedicated and channeled for that. Some sites with actual FTE allotments. Whoever wrote FTE, sorry if you could shout that out or what you mean by FTE, would be great. Did any of the sites actually do any sort of billing? I'm interested and curious to hear about how that process works. If you could you can go off mute and shout that out. So it says the rheumatologist considered billing for mental health screening with applicable codes, but did not do due to concern for patient barriers with an extra charge. No dedicated, as I said above, but shared social worker. Not sure if room section or Department of Peds pays for social workers. Okay, so I'm gonna just stop sharing my screen here and just open it to the group. If there's any questions or other themes that weren't covered, they'd like to share as a group. Love to hear more about billing as well. If anyone, thank you for the FTE piece. Yeah, full-time equivalent. Thank you, Susan. Yeah, that's helpful.
I can tell you that at Seattle Children's, we got very creative and applied to the hospital foundation. It turns out they had some matching funds, and then we had to fundraise specifically for that position as a psychologist in the clinic. So that was an option.
I think also just, speaking to your organizations or your institute and seeing if there is some sort of mental health strategy and funding or recent donation that's been made, and trying to see if some of those resources could be allocated to your clinics. And we just have to keep asking, right? And then be creative. And thank you, Alana, for sharing that information about billing. So just Alana and Elise as well has put in some helpful information about billing, which I think something is important since we are spending definitely some extra time with this in clinic. So thank you everyone for sharing that. That was very helpful. And then I could, if you want, move ahead with tips, if you'd like, Suzanne. Okay, so thanks again for everyone who joined. So this is just a quick cheat sheet of tips for successful implementation of mental health care in rheumatology setting, based off of kind of experience, as well as a great article here by Dr. Knight as well, and that you can look up, and I could happy to share that as well in the chat. So first thing is taking the time to characterize the underlying root causes or problems in your setting. So again, not jumping quickly to solutions and really trying to understand the problem of why we're not doing enough routine screening in our clinics, and trying to understand characterize these issues. The second piece is, second tip there is integration of proactive mental health care in the pediatric rheumatology setting. So again, asking about mental health personnel and resources. Do we have an on-site mental health provider or mental health navigator, coordinator? And doing a lot of education for our pediatric rheumatologists themselves and providers, patients and families, and trying to engage the different key stakeholders. Although, even though we might lack real-time urgent referrals, even just that quick phone call with a social worker or adolescent medicine, or even a multidisciplinary team meeting can be really helpful in trying to understand how we can get the resources to our patients. The third tip being optimal utilization of existing mental health resources, right? So let's work with what we have. So with social workers, and this has been researched and studied, that they are well positioned to deal with a lot of these issues on hand. Also being mindful that some of our social workers really have been stretched out thin, maybe shared by several departments. So, but looking for ways of how we can increase their involvement. And the second piece is streamlining access to psychiatry and adolescent medicine. So looking over that referral process and how we could streamline that process and access. And then the fourth tip here is strengthening that communication and education with community providers, mental health providers. So not just looking at your own institute, but outside and in the community, what are some of those resources available to patients and families, and even involving the family physician and the general practitioner as well, and looking at that avenue. Ensuring your goals are aligned with institutional goals. And I think that's just coming off of really what I experienced at our institute, in that once they've heard that we were doing this in our own clinics, we were fortunate enough that we've been recruited now as a pilot for the mental health strategy for sick kids. And so this wouldn't have happened if our initial vision and aim statement, we may ensure that was aligned and synergized with the mission of the Institute. And so I really encourage that you look at what's going on at your own institute and try to align that. And then accessing, looking at peer support resources to you if there's, if that's available, and how to improve access to that, because I think that's really been emphasized by patients and families being extremely helpful. And lastly is paying attention to sustainability, feasibility. So once you do have routine mental health screening in place, and trying to ensure that there's some sort of follow-up. And one of the ways to ensure sustainability is trying to automate as much of this process as possible. So working closely with IT or, EPIC team members to try to incorporate these patient-reported outcomes and even questionnaires into your system. I'd like to thank everyone again for listening to these tips.
So I have one more quick slide to share with people. For those of you who want CME status, please fill out your evaluations. And if you need more information about resources, we have quite a bit of mental health resources on our CureJM website. And if you need any specific help, please do not hesitate to contact me. And if you have ideas for further workshops, please let us know. I want to thank all of our presenters today. Matthew Stern, also at Colorado Children's, says if you have not signed in yet, he's put the link in the chat, and the 6-digit code for getting your CME status is in the chat, TELMOP. And I'm really grateful to everybody who was here and stayed and presented.